The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. Okay, everyone, welcome back to another episode of the Success in Practice podcast. Today is a special episode. It's the first time I've actually had two guests on at the same time. So it's the first for us, or for the podcast. I'm joined today by Anne Cooper and Stiofan McSweeney. Anne is the owner and operator of Central Sydney Osteopathy, located at Petersham in Sydney's inner west. She's been qualified as an osteopath since 1990 after completing 89. Sorry about that, Anne. 89 after completing her studies at the International College of Osteopathy in 89. Stiofan also works in Sydney's inner west at Central Sydney Osteopathy. He's worked at the Osteopathic Council of New Zealand, the Australian and New Zealand Osteopathic Council, as well as the New South Wales Osteopathic Council and Osteopathy Australia. So it's nice to have a bit of a panel to discuss some things. We thought we'd just talk about some topics that have come up for me in the first 50 episodes of the podcast. We're up to episode 53 as this goes to recording, but by the time we publish this one, we'll probably be around 57. So that's good. My wish when I began this was to get to 100. So we're cruising along quite well. But it's good to have Anne and Stiofan here with me today. And I want to start off by just speaking about the osteopathic rationale, the philosophy of osteopathy, because it keeps coming up in the podcast. And one of the things that I've been asking, especially the experienced practitioners that I've had on, and I haven't had a chance to ask both of you because I started this recently in the episodes, is I've asked them, what is osteopathy? What is an osteopath? And it's interesting what people say, and a lot of the feedback has been that, there's a bit of talk, and then invariably it just winds its way back down to the principles and the thought process and the rationale of an osteopath. So I guess what I wanted to have a discussion to start off with about the osteopathic rationale and what it means to each of you, and I guess what are the key components of it that make it stand out in the health space. Anne, we'll give you seniority.
Well, thanks very, very much. Without it, we're nothing. Without it, we're just an empty balloon. We'd be treating in the dark. Well, actually, that's not fair enough because people do treat in the dark. We'd be treating in ignorance. We wouldn't be able to connect one sensation that we receive from our palpation to another. We wouldn't be able to connect the medical conditions or the musculoskeletal conditions without those things. I've been thinking about it quite a lot. It occurred to me the other day that carotid, the blockage of the carotids it happens bilaterally. It's at generally the internal carotids, and I've been thinking, now why does that happen? And of course, mostly it happens at Mostly it happens where the carotids split to the internal and the external. It's a hydraulic thing, but that's at the level of 3 and 4, cervical 3 and 4, which is the main place that we see a torsion in the cervical spine. So I'm saying, well, this is osteopathy, isn't it? Is this pathology but also being caused not just by diet, and I'm not going to dispute anything like that because that's not within my ability, but is this being caused by having a torsioned and compressed neck? Would you be able to correlate, and this will never be done, people who have blocked carotids, atheroscleroma of the carotids with poor neck mobility? That's osteopathy. And while someone may have blocked carotids on both sides, it's not like you're going to go and adjust their neck, but you can certainly increase their mobility. So is that something else that we can do? Does that also apply to the aorta, and to anything else in the body that is a hydraulic system which gets compressed and torsioned and therefore doesn't function well?
Well,
I
I
know I've
wonder.
dived straight
I
in.
I wonder that how many people have been walking around with some, I guess, anything that might obstruct the carotids that have just been flushed out due to a really good hydraulic pump. And had they not had that, would occlusion happen a lot quicker? We'd never know that. I mean, but
And it fits
yeah.
our philosophy, doesn't it? If you call it a philosophy, it fits our matrix, doesn't it?
Mm.
What do you
It
think?
does. It does. I'll ask you the same question then that I've been asking people. What is osteopathy, Anne, to you? What makes an osteopath?
Osteopathy is very simple. It's a system of medicine, of musculoskeletal medicine. I'll get you to edit this, please. It's a system of medicine using the adjustment of structure to influence function. So optimal structure, optimal mobility allows someone to have optimal function.
Right.
It's a
Okay.
system of medicine.
Okay. And I guess you've touched on the structure and function aspect of it. The self-regulation aspect. How do we account for that? Like, where does this come from?
Well, that's a mystery. That's the burden we have to tolerate, isn't it? It's the burden of not knowing things. Do you remember in the Terminator how the robot would get injured and
Yeah.
there'd be a screenshot of it healing, and it was miraculous. That happens to us every day, every second, every minute. Every time a cut heals, that's exactly what's happening. But we're not thrilled by that. We're thrilled by something we see in the Terminator.
Mm.
Self-regulation is what keeps us alive. It's homeostasis, isn't it?
Yeah. Yeah. Stefan, I'll get you to weigh in on this, mate. Have you contemplated? I'm sure you have, like most osteopaths. Have you contemplated on the osteopathic rationale and what it means to you?
Look, I think that first up, I think osteopathy is it's a system of medicine or healthcare. It was also a reform movement. It was initiated as a reform movement of orthodox medicine, and it's also a set of techniques. So I think that it's a philosophy and a practice and a profession, and I think it's really hard to just. I mean, we can reduce things to the four basic principles, or whatever, and I think that's sensible. But then we have to build it up, and so that's a lot of waffle. But I think osteopathy. There's probably not one osteopathy either. I think that's something we're not very good as a profession. We're not very good at saying there are different osteopathies. It has been around for over a century. So I think there are different kind of parishes within osteopathy that are very different. I mean, if you look at kind of structural osteopaths versus cranial osteopaths, there's a lot of overlap. People do both, but there's also a complete separation as well. Some people, will talk about, I work indirectly, and then when you try and figure out what they're talking about, it's quite complicated, I think. But I think that we also now have the kind of emerging kind of osteopaths who are more interested in exercise, or kind of are captured by evidence. The long answer is I think there are many osteopathies, and we need to acknowledge that our philosophical underpinnings are not necessarily always translated into therapeutic processes, and some of them are observations about the nature of complex biological systems. Um, so yeah. I have thought a lot about
I had
what
a
osteopathy.
sorry, I was having a conversation with George Stillian a few weeks back, and he doesn't like being called a cranial osteopath, although he started off very structurally. And George, Anne,
Mm.
much like the men that were teaching at the International College there with Ivan and Peter and Stephen Porter and co, and George himself as well. They were all fantastic structural osteopaths, and then a lot of them moved on to more indirect practitioners, and they don't see themselves. They don't like the whole "I'm a cranial osteopath, I'm a structural osteopath, I'm an indirect, I'm a direct." They just think that it's all osteopathy, and to a certain extent, I have to agree with that, because I can sit there and listen to George speak and learn a lot from him and agree with a lot of what he says. I mean, we had a chat about, the foot, and talking about the arch of the foot being one of the first springs of the body, and when you remove a lot of that springing effect, then the next spring is the lumbar spine, and that has to build up the pressure, and that's why we often see a lot of lower back pain from poor foot function. So the kind of thought processes that he speaks about, I can go, yeah, that makes sense. Osteopathically, my brain kind of connects with his, and although we might treat differently, we can kind of talk about the same rationale, and I guess that's what we're all trying to. I think where good osteopaths converge, is around that rationale, and also speaking to Lisa Di Stefano, who's got this structural cranial approach. She likes to move the cranium quite structurally. And I'm not a cranial guy. I wasn't, but I went and had a chat with Lisa and saw her, did her course, and there's a lot of research and a lot of anatomy and a lot of physiology and a lot of thought process has gone into what she's done. And I couldn't really fault her approach from a rationale point of view. Now, if I were to go and apply it tomorrow, I wouldn't be nearly as good as she is, and so I don't want to I don't want to bash the approach because the practitioner wasn't as good, and I'm talking about myself. Um, so the next question I have for both of you is that, do you think we can find common ground around the rationale of osteopathy? Do you think, when, like us three, we're all osteopaths, we're talking, and can we have a discussion and kind of go, yeah, that makes sense, Stefan, that makes sense, Anne? Or, even if things don't agree or don't align, do you think we can hash things out and get to a point where things kind of fit in an osteopathic framework? And I'll let you go first.
Well, I think you just did. I think you just told us that, what George was saying about the spring of the arch of the foot. I've been rabbiting on about that for 4 decades. Um, we're all singing the same from the same song sheet. We're just singing it differently, and I think we already are doing that. It's when the therapy that you deliver doesn't emanate from that matrix or that philosophy or whatever words you want to use. That's when it stops being osteopathic, and that's when it also stops making sense.
Right. You said earlier, Anne, you said, when I asked you earlier, you said that we affect the structure and that improves the function and we improve mobility. There's a lot of, the movement that Stefan was alluding to earlier about the exercise-based therapists. They're kind of coming from the other way. They want to affect the function. They're looking at function and trying to affect the function to kind of try to make changes in the structure. And so your approach is more practitioner, I guess. I don't want to say practitioner centric. I would like to say that I think you take more responsibility for the improvement of the condition that's in front of you, whereas I think the other approach is looking at shifting some responsibility over to the patient, and trying. And they would say that that's just empowerment. That's empowering the patient.
Well, they would say that, wouldn't they? They would
They
say
would.
that.
They
But
would.
I invite you to have a car that's got a very twisted wheels and unbalanced wheels and a twisted chassis, and you just drive the hell out of it for a long time, as hard as you can, to see if that improves it. Because that metaphor works very, very well.
Yeah.
I'm
Yeah,
sorry,
I
it
think
doesn't
I think
work.
also there is a kind of I think our philosophical underpinnings are very, very important. I think that gives us the common ground with which we look at, what we do. Um, but I think also there is a reality that a lot of osteopaths are proceduralists. They do procedures and they don't think about the underpinnings. And I think that's where I think that, things become tricksy about when we say that's very osteopathic, um, I think we need to be, we need to be clear about what we mean. But I think when people are just doing procedures, I learned a technique and I'm using it, that becomes more problematic. And I think, a really good example is dry needling. Riddle me that one. How does sticking a needle into a trigger point that's not there get wrapped up into osteopathy? I think that's something, it's very prevalent. Many of us are doing dry needling, but when people talk about osteopathy being holistic, that's the most reductionist, or one of the most reductionist things ever. I'm going to put a needle into your traps. Why? Oh, because it's dry needling. So I do think that we have sometimes a level of dishonesty about the kind of like the approach to practice. I think sometimes we do descend into proceduralism and we just do procedures.
So, Stefan, are you saying that the placement of a needle into the traps for the sake of doing that is the reductionist procedural approach? But if you're doing it within a schematic approach to the looking at the whole pattern, would that be then considered application within the osteopathic rationale?
I think it could be, but if you did a course in dry needling and you've done your 16-hour course and you learn how to needle muscles from the neck down, and somebody comes in and you just finish the treatment off with a bit of dry needling, it doesn't seem to me to sit within the schema. And I think that you could add into that exercise as well. I think it could be very piecemeal, and I think sometimes I see that where people are just so like taping, adding some taping. The blue tape is more potent than the pink tape or whatever. I don't know, but I think taping. That was very popular, and now it's less popular. At one point, everyone was taped. Now it's fewer and fewer. But I think these procedures. I mean, I had a patient today who she had an injury to her knee, and she went to see an orthopedic surgeon, and she said, "Oh, my ankle hasn't been right ever since I hurt my knee." And he said, "Oh, I'm not interested in that. I do knees." And she said, "Oh,
Yeah, right.
I wasn't very impressed with that." And I said, "Well, he's a proceduralist. He's probably excellent at doing knees, but he doesn't go below the knee." And I think some osteopaths get stuck on a very limited set of procedures. I may be one of them, I don't know, but certainly dry needling has been kind of bolted on, I think. And as I say, taping was big and then it wasn't big. But I think we're not immune from being rubbish. That's one of the things I'd say is that I think there's a lot of strengths to osteopathy, but I think, we have to acknowledge that sometimes, we go with fashions and we get led by the nose. So,
Yeah, I think one of the things, the main thing with what I found with dry needling is that, and whether you use it, I mean, if you use it like a myofascial release, I mean, it's sticking a needle into a trap might be the same as sticking your elbow into the trap and trying to get a good myofascial release on it. Whether you use that within the larger schematic aspect of a rationale, then that's up to the practitioner. But I think one of the attractions of dry needling is that it's easier on the practitioner, like it's not hard on the body. I think that's very attractive, especially to smaller females who might be treating larger men. It's that instead of getting their rolling up their sleeves and having to put their entire body into a technique, they'd much rather put a needle in. And it's not, I'm just using that as a
look, I mean, that's all fine, and that's all fine until there's a bilateral pneumothorax. But I think that the issue is I mean, let's go to proceduralism. Is the 16-hour professional development program that you put yourself through sufficient to bolt that on to a 4 or 5 year degree program and integrate it into clinical reasoning? So I think that that it's just a bit like, I mean, I did an orthotics prescribing course many years ago when I was clearly depressed and deluded at the same time, and that was very fashionable as well. And it's done so badly by people that do a short course, which is why I don't do it. I don't fit orthotics. I would say, I know a competent podiatrist. I'd like you to go there. And I think that, dry needling falls into that. I'm a have a go hero. I do a 2-day orthotic prescribing course. I don't do it because I realize that I'm not up to it. And I think I see dry needling often in that vein. So I think it's a procedure people learn and they do. Whereas I wouldn't want to shortchange somebody with an orthotic because
Yeah.
my knowledge and competence was too low.
I had an email today from somebody, one of the listeners of the podcast, who was encouraging me to have some people on the show who were very good. I'd like to, I think, and we'll talk to them, Carolyn Stone and Walter McCone, and so they're on the list, and I will be talking to them. But it was a very kind email, and he said how much he was invigorated by the podcasts and how he would be inspired by listening to people like yourself, Anne, and George, and some of the practitioners that have been around for a very long time. And he would be inspired by that, and that would change his kind of day-to-day operation, and how he felt like that would just bring back a bit of osteopathy into what he was doing day to day.
I think.
I want to,
Sorry,
yeah,
can I just interrupt? I think that
yeah,
Walter McCone and Caroline Stone. I know Caroline Stone very well. Walter McCone, I don't know well, but I've read his books, and I found it, very thought provoking. His books with all the kind of Goethe and kind of the philosophy. And I think with Caroline Stone, she has a particular genius in kind of talking about models of osteopathic care, and I think that is really interesting. But if I may share a story about Caroline Stone and myself,
sure.
many years ago did a course together integrating dry needling and visceral osteopathy in the management of women's health. And that was, for the record, the last time I ever taught a dry needling course because it was shameful. I said, I know Caroline very well, and I looked across the room, and she was making a funny face talking to a young man. So I thought I'd go over and rescue him or rescue her. Didn't know what was happening, and she was astounded at what she'd heard. The osteopath asked her whether she would, recommend dry needling the endometrium for menstrual tension and dysmenorrhea. And she was like, and so was I. And it was really difficult to accept that someone that had done a 5-year osteopathic degree could think such thoughts, never mind articulate them. And that's when I thought, well, I'm not going to teach dry needling anymore to osteopaths because I'm embarrassed. I was embarrassed by several of the delegates that I encountered, and their intentions and how they saw it as to be used next. So that was the end of my dry needling teaching for a long time.
Is that a slight on the people or on the procedure or the technique?
Nobody in the history of dry needling's ever done an internal dry needling procedure. I mean, to go per vagina with a needle and stick it into tissues that you can't see. I mean, it's so fantastical. It was just shocking. And I have taught quite a few people dry needling over the years, and then I've just felt very kind of deflated afterwards when people have reported back how they use it. So I mean, I should declare that acupuncture is a big part of my practice, but I think Caroline talking about her models are excellent. I learned a lot from Caroline working with her. She never taught me, but I learned a lot doing teaching courses alongside her.
Where I was going with that email is that he mentioned how some of the episodes had brought back some of the inspiration, I guess, from the mundane day-to-day experience. I said to him that I think a lot of the magic is found in the mundane, in the repetitive day-to-day things that you do that you then take for granted and somehow don't think it's osteopathy. When you just adjust the lumbosacral and you look at a psoas and you look at the effects of the connection that you're having on the pattern, and you think that you do because you do that on so many people, because so many people present in a similar fashion. That becomes a little bit mundane, but I think we stop seeing the specialty in that, or the I guess, the magic in it. And you would have some things to say about that, because I think,
I got an
practice.
email last night from a person who's worked with me, and this is what he said, and it was so lovely. He said, I was thinking today, I've had so many friends and patients who are getting made redundant, are stressed, are qualified but not making much money, and their jobs have been taken over by AI. I didn't know that was already happening. I feel incredibly grateful to be doing what I'm doing. I think it's rare to be in a job that you love and also to be earning a good wage and not working stupid hours. So I wanted to thank you for facilitating that. I think I take it for granted sometimes, probably most of the time. But with all the uncertainty in the world, it's really highlighted how good I have it. And I saw a patient, I'm not seeing many patients at all. I just see basically old people who haven't been listened to. And I love it. I love seeing these people. And I saw a woman on Tuesday, and it gave me so much joy, and I couldn't fix her. I just said to her, I only saw her once, I said, you don't need to see me. You've got to stop spending money on people like me. You need to see the surgeon. But no one had told her that in 20 years. But nevertheless, it gave me so much joy to be doing my job. And that's, I don't think I've ever not felt joy in my job. It's always given me more than I could ever have expected. I mean, I just feel so lucky, so fortunate to have fallen into this honey trap of osteopathy. And if you don't, I think I've said this before, if you're not getting the joy, then I don't think you're doing the osteopathy. I don't think you're following that. It's almost religious, but I don't think you're following that path. And if you don't follow that path, then you won't feel the joy, because your patients aren't getting better, and they'll just be getting what they had from people before they came to see you.
Stefan, do you want to have just comment on that kind of aspect of doing the day-to-day grind of being an osteopath? Is that something that that you've thought about? That
Yeah,
does it?
look, I think, I didn't work full time as an osteopath until relatively recently. So I kind of felt the other day I'm just getting half decent at it as I'm on the verge of retirement, which is a bit depressing. But because I've worked in education and regulation for most of my career, as I say, it's only post-COVID that I've been working full time. And I think, I've always enjoyed working as an osteopath. It was always the part of the week I liked the most. And so, there is a certain amount of joy in it. And I think also, what you said about sometimes you don't see the worth or the magic or the specialness of what you're doing. I think that's also the case as well. And sometimes it's patients that bring that to you, and when they make comments about how they've got on. And Anne and I did a little project with long COVID patients a couple of years ago, and we evaluated it using an evaluation tool, and we got clinically significant improvements in all bar one of the 20. We did a case series of 20 patients, and I think all bar one had a clinically significant improvement. And it was really, really interesting, because Anne and I, although we share kind of a lot of common thoughts on osteopathic practice, technically we're quite different, I would say. And but it was interesting in terms of patient outcomes that we got, say, all bar one of the patients had a clinically significant improvement. And we were doing very basic, whatever that means, osteopathy, working on the kind of like the mechanism of breathing, working on the accessory muscles, the respiration, the ribs, the articulations of the spine. And it was very interesting that the breathing side of long COVID, if such a thing in fact exists, was improved by that. And we had intended to write it up and publish it, but like all geniuses, we didn't actually follow through. But I think that's
Yeah, well, Rosalba Courtney's made a whole niche out of breath work and breathing, and we know how important that is.
But I'd say that we were doing very kind of structural osteopathy, kind of hands-on stuff. I mean, Rosalba
Nothing
is
like Rosalba.
she's PhD, and she's an internationally, kind of
She's just, but she's
recognized
approaching
authority.
osteopathy from a different direction. It's still osteopathy. You're still ending up in the same place. I
Yeah,
mean,
yeah, yeah. She is. She's. I mean, it's wonderful though that you guys have, again, like you said, Stefan, different technical approaches, even between both of you, and especially probably between Rosalba, and yet you could arrive at a very similar rationale. I want to ask you, a few weeks ago, or a couple of weeks ago, you sent me an email outlining the general osteopathic treatment, as you would call it. I think we could do an entire episode on that, and we will. I want to do that. So I want to get you to maybe detail that out properly in an episode, but just give us an overview of that particular treatment and why you feel it's so effective in within your particular practice or within treatment.
well, it's something that Stefan talked about. Stefan talks about someone in the UK doing GOTs. Who was the one that taught that, Stefan? Is that fellow with the long hair, the old guy that
John
who taught
Wern.
the GOT?
I think it was
That's
John
right, yeah.
Wern.
But I'd never heard of John Wern when I was studying, and it's not important to me, but he's appropriated that, or someone's appropriated that for him. A GOT was basically you always had to balance the pelvis, then you go back down, you treat the ankles, you mobilize from the bottom all the way up. And as I keep saying, you can be the village idiot and do that. But if you're not the village idiot, you'll do a really good job. Either way, you'll do a good job, but you'll be a really good job if you're not the village idiot and you do it consciously and with awareness of what it is that you're treating and attempting to change. So the GOT is a way for me, which gets back to what you were referring to before. When you don't know what to do, when you're a new grad and you're completely flummoxed, you may have trained during COVID, which means you didn't get trained at all. And in some ways that's good because you're a blank slate when you come out to practice. If you just stick to that GOT, you will get great results. You will get a good outcome. And as you do the GOT, as you do that, mobilize the pelvis, adjust the lumbars, always do T12, do T6, do the upper Ts, adductors of the legs, mobilize the patella even, assess and mobilize the patella. If you can do all that at the time that you're building your skills, it won't take long before you become a really, really good and capable practitioner who's earning a good income and getting great reports back from your patients. Because in the end, the only thing that matters is what the patient says. And if the patient says, that feels great, then you've done your job. And I think a GOT allows them to feel great.
Hello everyone, I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
It's obviously a good starting point, especially for early career osteopaths. But
If you can make them, if you can make them hear you, if they listen to you, I'm not sure they listen very much. I think they just think I'm an old fart, which is true. But
oh no, they're listening. We get look, we get good feedback on the podcast now. People are listening, and I mean, I think, like I said, we'll do a episode on that because I think it deserves it. Because as you work through the rationale of it and the anatomy of it and the reasons why it's so powerful, there is reasoning behind that. It's not just like, well, we're just doing everything. And one of the things that I learned working with you, Anne, is that even when we were kind of moving up the chain or down the chain, you said it, you have to be aware of what you're doing. You've got to be present in the room. Your hands, your palpation has to be there. And if you put your hand on a hamstring or an adductor that needs to be worked on, well, you stop and you work and you move that. Then you just sweep things along as you go down. You sweep things along as you come up.
Sweeping's a good word.
Yeah, you have to be aware of what's underneath your fingers. And if you are, then you'll do really well. Stefan, what's been your experience in that aspect?
Well, it's interesting. I mean, I do something which I call total body adjustment, which is really just a rebranding of the general osteopathic treatment. And I think, I mean, Anne and I work together, and we've seen each other work on patients. We do sometimes, well, frequently actually, treat together, and it is interesting. I think that there's a rationale that goes beyond the individual techniques you incorporate in it as well. That you're actually treating the body as a single unit of function. And again, going back to using long COVID, using kind of like thinking about the lymph and the circulation of kind of lymph through the systems. That's something that you can do with those techniques of actually in total body adjustment, as was taught to me. You start with the right foot and you work up and then back down to the left and get the lymph mobilized and all the diaphragms engaged. And I think that's where you are actually being very osteopathic rather than reductionist, because you're saying I'm treating the whole body, I'm treating the entire machine. So that's an approach I use a lot, particularly in older debilitated patients. Wouldn't necessarily be doing HVLAs as part of that, but using kind of harmonics, using METs, and just working through the whole system. So yeah, that's something I value a lot. And maybe it's gone out of fashion in current training. I don't know, because when I've spoken to more recent graduates, they kind of think, well, what's the specific diagnosis? And that's where I say, well, one of the follies is that in osteopathic practice, there's a diagnostic therapeutic continuum. When you're doing motion testing, you are articulating. As soon as you start moving a structure, you're changing that structure and you're affecting its function. So the idea that you do this kind of like examination, and then you run it through your brain, and then you come up with a diagnosis, and then you do a treatment. Sometimes that's really important depending on the presentation. But I think part of the magic of osteopathy, and if we say what sets us apart from others, is this diagnostic therapeutic continuum, and the fact that we get on and we're listening to the tissues as we're moving them, so that we're actually diagnosing as we treat. Oh, that's interesting. I wasn't expecting that. And so on. And so I think that feedback, and that's where I think palpation does become, into its own. And it probably takes time to do that. You probably need, you need time on the clock to develop that. And that's something I would really have kicked back against 20 years ago. I'd have said that's not fair. I've got the knowledge and the skills. I'm on the register, but I do think that it takes a bit of time to, for it to seep in.
Yeah, right. Okay. So I guess then taking that approach of the general osteopathic treatment, at what point do you think can people start to become a little bit more like when you apply it, Anne, what makes you stop? Like what makes you kind of go, okay, I need to stop here and do a bit more work on the on the I don't know, the diaphragm, the thoracic diaphragm, or I need to stop and do some work on the pelvic floor. What
I
is it
think,
that what is it that you're sensing? What's the feedback that you get that makes you stop?
well, I think you've created optimal mobility for that structure for you to therefore be able to find the deeper structures that are not functioning or moving very well. So that word sweep is very good. You sweep along the whole body, head to toe, loosen up what you can. And once you've taken away the surface tension, then you can feel what's going on. I'm a great psoas girl myself. I think that's a terribly important muscle, and people aren't treating it correctly or even assessing it. Once you've got general mobility, and as Stefan says, you wobble this and therefore you change it. You wobble that, you change that. You fix the pelvis. You do those big things, and having done that, then you can get down to the specifics. And I think that's what's really important, and that's what relates very much to what the patient is complaining about.
Yeah.
We don't ask women enough, and I'm sure there's questions to ask men, but we should be asking every woman over 35 what her continence is like. We should be asking these things. If it's a menstruating woman, ask if it's painful periods. If she's not, if she's over that, ask about continence. Ask about things like this, because they're telling us what's going on deep inside the pelvis and in the thorax, of course, in the thorax. We're not asking enough questions, and that's another thing I really dislike, is people sitting down at a desk and taking a patient history like a GP does. They don't even do that anymore. I think in our clinic we get them to fill out a form, whether that's online or in handwriting, which I like the handwriting because I like to look at people's handwriting and spelling. It tells you a lot. And then lay them down and keep talking to them so that what you're asking correlates to what you're feeling. And that's 10 times more information than what you get from just sitting apart from them and not touching them. But you're treating them, as Stefan says, you're treating them as you're assessing them, and you're taking a history at the same time. That's a very, very powerful way of managing a patient.
Yeah. Stefan, anything to add on that, mate?
No, I think that of course, it is important to get really, and what Anne is not saying, it's not about not taking a history. It's about using your palpation and your mechanical kind of psychomotor skills as part of that diagnosis. And I think that is important to actually start moving people around. And yeah, I do think the total body adjustment, which, by the way, was rebranded because people didn't like the term general, because they didn't think that sounded scientific enough, that it was a routine. And I think that, the elements of TBA, as I understand it, having routine, rotational, kind of movements through all the body's quadrants, I think it's very, very worthwhile as an approach, well worth learning.
Yeah, I guess the approach that Anne was talking about palpation and diagnostics and therapy all kind of melting into one pot, I think also has to be taken in the context of what you said earlier, Stefan, about the time in the trenches. The more time you have, the better you get at that.
Yeah.
I think that just evolves naturally. I want to ask you, I've had multiple conversations with practitioners on the podcast regarding the multidisciplinary approach, and this is becoming a very, obviously, with the rising costs of running businesses and things like that, and also the advantage or the fun, the culture associated with having different types of therapies within a practice is very attractive to the modern osteopath. Where do you guys stand on the multidisciplinary approach to, treating a patient? And does that kind of democracy work best or work well when it comes to, treatment? Stefan?
Well, I have, before I was an osteopath, I was a manager in the public health system, the National Health Service in the UK. And I think the term multidisciplinary, team means very different things. In public health system, it's important to understand that midwifery, nursing, podiatry, the allied health and medicine are part of the patient's kind of like healthcare ecosystem. And I think the
Let's
problem.
talk. So let's talk about what we do. I mean, what we're seeing now is the sorry to cut you off, Stefan, but what we're seeing now is the physiotherapist, the chiropractor, the osteopath, the naturopath, and maybe a psychologist and a
Yeah.
acupuncturist
Well, I would
in
absolutely
in
say
the
that's
same.
not a multidisciplinary approach to healthcare. That's just different professions sharing space, and I think that there's nothing wrong with that. I mean, as I say, I managed a sports medicine business for a number of years where there were physios, osteopaths, Chinese medical practitioners, dietitians, naturopaths, and so on, and that was approaching kind of multidisciplinarity because of the context. It wasn't in Australia, the funding mechanisms. But I think what's happening in osteopathy clinics where there's a range of practitioners is not necessarily, I think it's a misuse of language to describe it as multidisciplinary, because I don't think people are, kind of working in that space where it's shared care. And I think it'd be more useful to talk about scope of practice. If you've got a physio, an osteopath, a chiropractor, and myotherapist, the scope of practice is identical, except for
Mm,
HBLA. So I don't see that multidisciplinarity comes in. Whereas if you've got midwifery, you've got podiatry, you've got osteopathy, physiotherapy, I think one of them is looking at it from the point of view of a business, having different modalities. The other one is looking at that healthcare is complex. And when you talk about democracy, I had understood that in the moment to be, well, who's the lead care, who's managing care there, who's the lead clinician. And I think in general, that is the GP in the multidisciplinary team. But in private allied health situations, I think it's probably different.
right. And
Well, I don't think it works very well. It's never really worked in our clinic. Basically, osteopaths work well with other osteopaths as long as they work fairly similarly. I mean, I think we've got 9 osteopaths, and each one of us works quite differently. But still, as I say, we're all singing from the same sheet. But if you have a chiropractor who's working like a chiropractor, and if you have a physio and a myotherapist and an osteopath, and they all treat back pain, they're all going to actually treat it quite differently. There's a post on Osteopathy Works. This bloke said that he thought that osteopathy, chiropractic, and physiotherapy should all just be one profession because we all do the same thing. And well, we don't. You can imagine my response to that. We don't do the same thing. We do different things, and we do it for different reasons. This patient I saw the other day for 20 years has been seeing a chiropractor and a physiotherapist. The physio does massage, and the chiropractor cracked her back with no resolution whatsoever. But no one had actually gone further than just looking at her L5 region or massaging her glutes. Can you believe it? Gluteus. It's not multidisciplinary. It's different approaches, but I can't call it the multidisciplinary because we're all actually treating the same thing. And so it's not like we're coming from a different discipline. It's a very subtle thing I'm trying to convey here, but there's no discipline there. This is, to me.
well, it's used as a pretty heavy kind of marketing strategy for
Well, that's it.
clinics.
It's exactly it, Sammy. It's marketing. Everything's a new bloody fashion. Everyone's got an eating disorder now. Everyone's got a neurodivergent diagnosis. Everyone's got something. Everyone's got to
Everyone's
take
on the
a pill
spectrum.
every day. Everyone's got to take a pill every day for the rest of their life because they've been told that it's and what is it? It's nothing more than a marketing.
Well, what I was saying is that it's a marketing strategy or a ploy as well from clinics to attract therapists. I think and it seems like it's like glamorous, to
Well,
work in a
we've got a busy
team of
clinic.
people.
We've got a busy clinic, and
Mm.
we're osteopaths. We don't
Yeah,
have to pay anything
yeah,
more.
that's right. But I mean, I want to kind of clarify the points there because Stefan said that we all those professions that I discussed we're kind of all within the same scope of practice. But yet, Anne, you're saying that we have different approaches and we look at things for different reasons, right? So what that really means, from what I understand from the both of you, is that we're all competing for the same scope,
We are. The same
but we're all using different methods.
I don't think this. Why does a chiropractor adjust? A chiropractor who's a classic chiropractor adjusts in order to remove irritation or compression of nerves so that tissues get good nerve supply so that people don't die early. I mean, that's the kind of term. What does a physio do? They do exercise physiology, exercise, and they massage people. They get the patient to do the work. What does an osteopath do? An osteopath mobilizes tissues in order to provide the best and optimal supply and drainage so that the homeostasis can take care of it. With good diet and with reasonable levels of exercise, you'll have a state of health until one day you drop dead. And we don't know the answer to that bit.
Well, they're three very different approaches.
Exactly.
But they're all going for the same scope.
Well, I think that the scope of practice conversation is really interesting because the scope of practice is something which is really underdeveloped
Osteopaths don't have a scope.
Yeah, and so but I lost my train of thought there momentarily. But I think yes, we're competing for the same in the ecosystem. We are competing in the same space. And I do think there's also been convergence between the professions over the last quarter of a century. I think there was much more distinction 25 years ago than there is now. And I think that's one of the reasons the conversation about philosophical underpinnings is very important. When I was a regulator in New Zealand, I remember talking to my opposite number in podiatry, and she said, "You're so lucky that your profession has an underlying philosophical platform. There is no such thing in podiatry." So in most of allied health and nursing and medicine, you'll hear people talk about biopsychosocial like a mantra, but how do you do biopsychosocial healthcare? That's a question that's very hard to answer. So we've got we do have that philosophical underpinning, which I think is one of our unique selling points, because what we do could be identical to the physio, the myotherapist, or the chiropractor. What we do could be
exactly and we can say to the patient, this is why I'm doing this, and this is how this connects to that connects to that. And we can say that. The physio can't say that. The physio says, no, that, or the surgeon, no, that ankle has no relationship to the knee, even though they're different ends of the same bone, even though they're different ends of the same muscle. What does the physio say? The physio says you've got weakness, so you have to make it strong, which is absurd. It's risible, ridiculous.
I think we can't presume that entire professions think similarly, and I do think there's a great deal of overlap in thinking. Regional interdependence in physiotherapy is something which is, whether it's borrowed or stolen from outside physiotherapy is a separate conversation. But I do think that we have a crisis of convergence. If we are to, like that osteopath that you're referring to, Anne, that said that, we should all merge into one super blob. I mean, in some respects,
we are moved.
Yeah. In some respects, perhaps we should just do away with these distinct professions and have, a pathway, physical medicine pathway, and then you do postgrad specializations in chiropractic technique, osteopathic technique, exercise-based approaches, occupational, OT type approaches. Maybe that's a good thing to do, but I can't see it ever happening because of the structure of the education system and the structure of the healthcare system. But we certainly need to maintain a connection with our philosophical origins.
Yeah, that's definitely something I would agree with. I hope that happens in Australia. I mean, that's something that we need to hold on to as a point of difference. I spoke to someone on the podcast yesterday who mentioned that the palpatory experience of the osteopath is also a point of difference. And I guess what you were saying earlier, Anne, is that a physiotherapist might mobilize an ankle for the sake of the ankle and just wouldn't think about the improvement of the knee and the hip and the pelvis.
Well, I disagree there. I think the physiotherapist doesn't mobilise the ankle. You sprain your ankle and you see a physiotherapist, they do rice, don't they?
Well, if they did, I'm saying if they did mobilise the ankle, their rationale would be for the sake of the ankle.
Yes, that's right.
Whereas your rationale would be for the sake of the entire system.
Well, that's what I said to one of the associates the other day. A new grad, a woman was coming in with vertigo, and I said, "You've got to ask if he or she, or it's a she, had sprained her ankle because, the semicircular canals are the screen of the TV, but the signal is coming from the rest of the body, and the aberrant signal starts with the foot and goes all the way up, and then through all these big muscles that go from medially to laterally and front to back, all that stuff." And he said to me afterwards, he messaged me and said, it was like she read your email. What had gone wrong with her.
Yeah, right.
So anyway, getting back to the physio, they're not going to, yes, they're going to look at the ankle as if it's a single area that has no relationship to the others, but also, there you go, you should have, you brought that up, rice. They will do rice. That is, they'll elevate it, they'll compress it, and they'll keep it still. An osteopath will try and correct the alignment so that it rests, ice, I forget what they are because I don't do it.
Compression and elevation.
An osteopath will
Compression and
correct
elevation.
the alignment, correct the talocrural joint and everything that they possibly can simply by tractioning it, and then allowing it to heal in the correct alignment. Anyone that's seen a physio who's had a bad sprained ankle and that they followed the RICE protocol still has a sprained ankle. It can't, it's not like it corrected itself anatomically. It couldn't have, mechanically.
Yeah, well, I guess then, like I said, your particular communication then can be, as an osteopath, can be something that that you use to discuss in terms of talking to them about the rest of the body, the knee, the hip, the ankle, the pelvis, the rest of the structure, and the vertigo, exactly. I think one of the things that leads me on to, it's a good segue into that, is that it seems like when you speak, Anne, it's and also yourself, Stefan, when you speak, you guys are quite powerful in your speech, and I guess you can communicate that to the patient. You can kind of say, look, this is why we're doing things, and you can have a quite a good conversation there, and people kind of buy into that. How much of that do you think is personality and charisma? How much of that is important as a practitioner to have that kind of conviction about your speech, so that you can actually get the patient to allow you to lead them in the treatment journey? Stefan?
Well, I think we need to be able to develop rapport with patients. People are people, and so people buy things from people, and they're buying healthcare from us, and I think we need to be able to communicate with them. We need to persuade them, to cooperate with the program and so on. So I think it is important to have good communication skills, but I think there are very different styles that will work, and everyone is different. But I do think establishing rapport and trust, I think, is key in the therapeutic relationship. I mean, there's therapeutic alliance is a really important aspect of any allied health professionals' interactions, or medical doctor. We need that. The patient needs to know that we are their ally in restoring health, and I think that is really important. Really important.
It's important that they know it, Stefan, but how important is our skill to be able to communicate that? Like, some people can do it very well and really quickly and have that buy-in happen, and other people just don't have that. Like, have you noticed that? Has that
There's
something that
different
you've seen?
styles. Some people are, their physical presence and all the rest of it. I think it's very, very different. When I worked in sports medicine and, working with, kind of elite rugby players and so on, they would look at me and they wouldn't see somebody that they would admire physically in their world, because I'm, not that kind of specimen. But they might appreciate other aspects of my communication. And so I think it really depends. It's a rapport, and I think it's very individual. One thing I would say is we cannot please all of the people all of the time, and some people are better suited to other practitioners, and some patients are better suited to me. I think there is a horses for courses aspect as well.
Yeah.
Yeah.
Yeah. And do you? I mean, you've had a lot of practitioners come through your practice. Do you get your practitioners to treat you? Like, is that one of the things that you do to screen? I
No,
mean, maybe not now, but back in the day,
no,
did
never
but
did.
once you had practitioners come on board and work with you, were you often treated by them?
No, not unless I needed treatment myself.
So if you needed treatment though, would
Oh
people
yeah,
at your
I
yeah,
needed
right. And so
lots.
you've obviously come across the really great, fantastic practitioner,
Mm.
lovely skill set, just clean adjustments, really beautiful to watch them work, but they just couldn't communicate. Have you had that kind of practitioner that
Yeah,
really had
and I
trouble?
those people have to basically they almost have to learn a script, and they learn the script until they really start believing in themselves. And you can tell when someone doesn't believe in themselves because they don't rebook. You don't have to rebook 12 times, but you have to rebook certainly the first time you see someone, and they don't rebook. They're the person that says, oh, to the patient, oh, look, if you feel better, you come back, and if you don't, you should be all right. That's actually poor self-confidence, and that's not sustainable practice.
So
So
so how do you? I mean, how do you? I guess make that up, or how do you align that in your brain? How can somebody be so good at what they do?
with new graduates and new people, I often work a lot. I actually co-treat with them, and they listen to my spiel and me rabbiting on. And I think just as I did from the men and women who taught at the ICO, there were women, a lot of women who taught there. Um, I listened to them, and I remember conversations. I remember whole phrases that people said in front of me about whatever they were teaching, about their osteopathy that they were teaching. And I think those things are what stay in your mind, and you just copy someone else. I remember Peter Cash saying, he was teaching us how to do a particular manipulation. He said, just look at me, then close your eyes and pretend you're me. And I think that's what I've said to many people. Just pretend you're me, and then sometime in the future, someone will be pretending that they're you. That's the way it works. It's not showing off or anything. It's just that's a way of learning. But they listen to my spiel, and I'm not telling lies. I can't be bothered telling lies. I don't need to tell lies. If you tell lies, you've got to remember the lies you told. And I can't be bothered. So I don't tell lies. I just tell them what I think, and what I think is said very clearly. And I think when I'm working with the younger ones, they hear that and they find their own way of saying the words that they've heard me say.
Yeah, I
Sometimes,
guess you've got to be patient with them too. Like they've got to find their own way and they've got to come along. But also, I mean, it's a two-way street too. Like it's a hard one for practices because especially if you find a very talented osteopath that just doesn't have great self-belief in what they do, it's really hard. That's the harder one. Getting the practitioner who's really charismatic and has a really bubbly personality, teaching them how to do a lumbar roll is a lot easier than teaching someone how to communicate and how to speak. So you can always fix that up.
Yeah.
But
Well, one of the people
Stefan, yeah,
that that encountered when I was being trained, he was a medical doctor and also an osteopath and a psychotherapist, and he said something which I've always remembered. He said, "Whatever else osteopathy is, it's the interaction of at least two sentient systems. So you can't get by on technique. That's not enough. You need to, if we actually go back into our philosophies and the triune man in the language of Andrew Taylor Still, body, mind, and spirit, whatever the spirit component is, we'll park that one for a moment. But I think unless we're, open to the fact that the person brings with them their beliefs, their understandings, they're in a context of work, family, and so on, that I think that's really important. And that is something which I would hope that the graduates, that have trained in the university system in the last quarter of a century are good at. They should get that from their training. So I would say that that's a failing. That's an absolute personal, institutional failing if people don't come out with that understanding and the skills, to do clinical work. So
right. Well, Stefan, we had a conversation earlier about well, we just touched on it really. It wasn't a conversation about I guess osteopathic education and making sure that we don't lose some of the philosophical underpinnings of that within education, because from what you said, other professions see that as an advantage that we have. How do you see, especially given your experience in, I guess, education, how do you see the future, like the real future of education and osteopathic education? Like, given that AI is coming along and given that online learning is coming along so fast, and how do we take what we have, which is highly palpatory, and how do we then really streamline it so that we can
Yeah, look,
deliver it in
yeah,
a
look. I
very...
think this is a massive conversation, but I think that we can break down elements of our knowledge base, and some of it can be taught online. But I think in terms of one of the things I think that is very important is for neophyte practitioners and students to be exposed to different practitioners, and not for them to just be dumping content on them, but for them to have a dialogue with them and understand, their way of practice. So I think that's one of the things that's very useful in education, is to have, outside people coming in. I think, ever decreasing circles, getting very recent graduates to teach undergraduates. There's nothing wrong when it's very procedural. Somebody being an anatomy tutor, or, helping somebody with maths or something. But I think it's really, really shortchanging people if you don't have a range of practitioners to expose students to. I think it's important that they hear contradictory messages as well. That's really important, that they don't have, no trigger warnings. Different people think differently and they treat differently. That's important. When I was very opposed to cranial osteopathy, when I was a student, I thought it was nonsense, and that was the way I thought. And quarter of a century later, have I changed my mind? No, not really. But I do have friends that I respect that use cranial techniques. And, I just decided the model was nonsense. I couldn't feel it. Therefore, it had to be garbage. And that's an arrogance on my part. Absolutely. But I'm glad I was exposed to practitioners and came to admire people that use very different approaches to me. And I think that's something that you can design that into a program. I think that's something that, that can be done. But it means going to outside the academy and getting outside people in. And that maybe is something that the institutions have fallen short on in getting a practitioner perspective into education, rather than this kind of rarefied, curriculum driven, the tyranny of the curriculum. What's in the curriculum? What do we have to teach? Or what about, work readiness and so on? So I think that's a massive conversation. But yeah, I'm glad I was exposed to people who I didn't like. I didn't like their beliefs and I didn't like their techniques. I'm glad I saw that, because sometimes it could take 10 years to think, oh, I remember such and such. I won't name any names, but that's actually makes more sense 10 years later. So yeah, I'm a big fan of being exposed to a variety of thought.
Well,
Yeah,
for the last few years, we've
sorry.
had for the last few years we've had students come in from VU and RMIT. I think also from Southern Cross. Yes, but it's definitely from Southern Cross. And they spend three weeks with us or something like that. That's been wonderful. It's been wonderful. They've been treating their own patients, always with someone else with them, a registered osteopath with them. But even in that 3 weeks, you'd see this massive growth and this massive increase in self-belief and confidence in their osteopathy. And that's a joy. And, that costs the university nothing. Costs me nothing to have them there. And they've all been really, really a pleasure to have around.
Well,
I'd like to do more of that.
I had a discussion with the head of the RMIT program, and I think his episode will air, if not next week, the week after. He mentioned that he had a very unpopular opinion, and that students shouldn't be exposed to like external courses outside of university. And his rationale was that it kind of confused or conflicted or just didn't allow the process of what they're trying to teach at university to kind of be at the forefront. Whilst I don't want I don't want to comment on that at the moment. What do you think, Stefan, about students being? I mean, you mentioned earlier that you think that having people come in and exposing you to a different way of thinking than what you might like is a good thing. Do you think it's a good thing that universities encourage students to, I guess, have a wide scope or a wide scope of influence from different practitioners?
I absolutely do. Yes. So when I was working in New Zealand, we were linked paradoxically with Victoria University. We used to take VU students in their kind of like final year for 2 week internships in New Zealand. And I thought that was fantastic. It was really good for these, their final year to be exposed to different models of treatment and so on. I mean, I would say that there's a poverty of intellect that says we don't want to expose people to ideas that might frighten them. I think, that I don't want to stray into, very dark corners, but we can't, it's just difficult to be civil when I hear things like that. People should
Well, it's
know,
not just osteopathy, though, is it?
no,
It's
it's
not
not.
just osteopathy;
Yeah,
it's been affected.
yeah. I
This is
mean,
quite a trend across academic institutions that where speech
yeah.
that they're not happy with is shut
It's
down, and
absolutely,
that's
and
not a
it's
good thing.
paternalism. These poor, fragile, brittle intellects won't be able to cope with them. It will confuse
Mm,
them, and so on. And so it's a kind of like very kind of like I call it the seminarian approach to osteopathic education. It's like training to be a priest or a rabbi. There is a program and there is truth, and you will learn this, and then you will churn it and pass it on. And I don't think that's what osteopathy is. I think there is a free form aspect of practice. And I think that's why it's important to be exposed to different models. And I mean, I think myself, I trained to be an osteopath, and I had never gone and observed an osteopath in practice. That was a massive, massive gamble. What if I didn't like the job? I did
mm.
5 years trained to be an osteopath, and my only experience was being a patient, an osteopathic patient prior to training, and then in the student clinic. Well, the reality of practice in the wild may have been quite different. So, yeah, I think I'm all for having work integrated learning for students in their later years, and there's a lot of conversation. There's a lot of things that would need to happen to make that work, and it would require money and effort and so forth. But I certainly think we would be very unhappy if other healthcare professions only trained in simulation. Like,
And
doctors train in hospitals. They don't just train in clinics where the practitioners. What I'm trying to say is, a doctor
mm,
doesn't only learn doctoring as a student. They go and work with a big team of people. Some of them might have been qualified for 40, 50 years and so on. I think it's really important to get into the trenches and be exposed to that.
Hello everyone, just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So, the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes, so for more information, please see the show notes. Now, enjoy and back to the show.
and when you were at UWS back in the day, we often had people come in on weekends and do lots of weekend kind of seminars, and we all turned up very early on a Saturday and a Sunday morning after whatever kind of night we'd had, and we'd be very, very happy to do that. Um, is that something that you'd like to see kind of encouraged within university institutions, but also, is it something that you would encourage the students to do? Because I think one of the things that was said to me from the educators is that even when we do bring in these speakers, we don't get a great turnout.
No, I know it's a very different world nowadays, and people used to be so eager, jumping out of their skin to learn their osteopathy and to listen to any number of the people that we got in to teach you at UWS. Stefan and I would dearly love to teach, especially students. We'd love to be part of that. And we wouldn't charge. We don't need to charge for it. It's, I think we probably both agree in some ways it's our duty to pass on what we know is good. I'd like to go out to rural and regional areas too and help those people out there who are really struggling alone and see if there's better ways for them to work. Perhaps help them just streamline their practice and their coping mechanisms. I'd love to do it, but getting back to what you said, there's not the same eagerness, and I mean we were obsessed with it when we were training, and I think you lot were obsessed too. I don't know where it went wrong.
Yeah,
I think
we were quite obsessed, and I think we had a bit of a respect and an admiration for what I call the osteopathic elders, that kind of came before us. And so I want to ask you both about that. How do you think we should treat our, I don't know if you have a better word for me, please help me out. But how do you think we should treat our osteopathic elders, those that have been in practice for 40 years plus, that have done it for a very long time, and we really need to kind of cherish their own experience because that'll help us.
I guess what you're doing is good. You're actually talking to them online, but I get very irritated when I see on Facebook that one of the blokes has organised a Masters of Osteopathy seminar, and they've got 5 blokes, and one of them is bringing on his wife who's an osteopath, and so there's one female. There's so many women that out there who are just not taken any notice of. And, you've got to remember a successful woman is always a bitch, but when they're at like me and plenty of others, but there's some amazingly successful and effective female osteopaths out there, and they're ignored. The men, because there's even a word for them, masters, they all slap each other on the back and check their times with each other, their running times or their weights that they're lifting. They all pat each other on the back, but the women are ignored, and that shouldn't be happening because they've got so much to offer. I think what you're doing, as I said, is right. I don't know how else to honour them. Some of us are mad, and you've got to accept that you can go mad quite safely as an osteopath, and there's quite a few of us around who are mad.
I mean, one of the things one of the things I think is interesting is that when I trained, people would say who trained them and then who trained them, and it was very much like apostolic succession, the laying on of hands, and people would trace their lineage back to kind of Taylor Still's time and so on. I think that's been lost, and whether that's a good thing or a bad thing is not what I'm saying. But I do think that it is important to harvest the experience of people before they stop practicing. And I think that this is one vehicle for doing that. I would also say there's no fool like an old fool. That and I'm not pointing at anybody in particular, but I think it is important to acknowledge that some people do get wiser and accumulate knowledge and experience, and other people, they actually lose as they mature. They lose the repertoire and they become very self-referential. And so I think that we need to balance kind of referentiality of people that have been practicing for a long time with kind of being open-minded to the fact they've just gone stale. So now that I am male, pale, and stale, I need to be careful. But we
had a seminar in New Zealand years ago, and that was great, where we just got a whole lot of older practitioners, and I think it was in Christchurch before it fell down, and I think we had about 50 students there and 10 tables. And students just went from one elder to the next with the same problem. Everybody, the pretend patient had the same problem, and that elder would then talk about how he or she would manage that problem. And that was fantastic. And maybe that's what you're getting at, Sammy. They should be invited to the universities. They should, but they can't do it alone because we're all too unilateral in the way that we think. We're best when we're with others and we can share and argue and learn from each other. But doing it with older people is wonderful.
It is wonderful. It's something also like that we need to help them because they may not be technically gifted in the, I guess, in the administration or the technology of how to administer education. But if we can help them that way, and that's one of the things that this platform's doing, is just kind of, putting them on a screen and recording their voice and having that on record. But it's so valuable in terms of practice to actually learn the actual education and the past experience. I mean, you're not going to get that anywhere else. There's such a value in time and the volume of patients that they've seen and the amount of things that they've seen that you could really shortcut your own experience by learning from them. What I do want to speak to you about, Anne, is you mentioned, look, you've mentioned this before on the podcast, and I guess I want to flesh it out with you a little bit about, the men, the masters kind of patting each other on the back and doing the courses, and there's been a lack of female involvement. I have to say, I mean, everywhere I look online, there's a lot of these, female health, pelvic health, reproductive health courses, and it's inevitably women that are doing it, and I don't see them tapping other women on the back. And so it's not just the blokes that are. I think it also comes that there's a lot of really competent women out there who are doing some good things in terms of putting osteopathy on the map, and I think they just need to tap other women on the back too, and bring them into the.
There's too much chest beating in males and females, but we're yet to have a seminar where it's only women teaching, where we have plenty of them where there's only men teaching.
Well, I think women have to lead that, right?
Well, maybe that's true. That's true.
Women should lead that. I mean, look,
unless they're asked, Sammy, they don't do it.
Yeah.
They're not push themselves forward like these blokes do. They will not do that. As I say, we don't even have a word for a woman who's expert. It's what we call her a mistress. We can't even do that. But you're quite right. Women are they're listening to the podcast too. They're becoming so-called entrepreneurial, and they're selling themselves as in ways that they can. But you've got to remember that the vast majority of our patients are female. 70% of our patients are female, and that's a real pity. That, to me, that's a national tragedy that men aren't seeking healthcare. Especially, in my family, our men are dying too early, and I'm sure that's happening in many, many other families. And men don't seek healthcare. So
I got to connect recently with John Marshall in Melbourne at one of his courses, where I went and saw Lisa Di Stefano, and John bought Lisa out. Like, she's a female, obviously, and a very good osteopath, and she's head of the program there at Michigan State University. And I mean, I get along really well with John. We're similar in that way, and we've kind of helped each other out in the past few months. He's helped me put on some courses, some face-to-face courses that I'll be running, and I've helped him out. And I think women can do that as well. I mean, there are plenty of women running courses out there, and they could tap you on the shoulder. They could tap.
You were talking about the elders. And generally that's thought of as being the men, and the men say, "Yep, I'm the elder," but the women generally don't stand up. That's what.
I mean, I've noticed that more and more there's less kind of professional development that's actually run by experienced practitioners. They tend to be mid-career people. There's nothing wrong with that, but anyway, I don't know whether we could talk in ever decreasing circles about people not doing things, but I've done very little osteopathic education in my career. I've hardly ever gone to an osteopathic course and paid money to learn things. Most of my professional development has been in acupuncture, mindfulness, different areas, so in that I might be a bit of an outlier in that I've kind of chosen, I've chosen other avenues rather than kind of turning up for osteopathy stuff.
And I think also, after a few years, you stop listening to other people much. I think you've got to get the fruit when they're young. And so, if we could reach people in their first couple of years of practice or their last few years of study, that would be wonderful. And we'd very happily do it. But universities won't take us in because,
Yeah, well, also, I mean, once you get into a clinic and you get busy, you've said this before, Anne, there's nothing new under the sun, right? It's like you don't have any new ideas. Osteopathy is it's really hard to come up with a brand new, idea in osteopathy. It's very difficult. I haven't come up with one yet. And so, that presents itself as a challenge. But I just speaking on the topic of John Marshall I brought up earlier, he's actually now he's taken on a position with Michigan State University, teaching the osteopathic approach to headaches and migraines. So that's really good for us Aussie osteopath that he's trained and he's over there now with Lisa and doing that. So that's really good. But one of the good things that he does is that when he runs some of the courses that he does, he'll often invite students to come and do some work with him, whether it's in HVLA or whatever it is that he's running, and he'll do that either for free or for very little money. And his rationale to me was that, well, I'm paying for the venue, I'm here anyway. We might as well get these students in and give them a bit of practice. And so I think we should be doing more of that. I think we should be kind of getting together and doing more of that stuff for the students, especially. Although we can't do it because there's obviously no course in Sydney, but definitely the ones in Melbourne who are putting on courses that should be doing something like that.
I don't think they want us there. Actually, I don't think they want us.
They don't want us. Who doesn't want us?
The universities don't want us.
Right. Well, who knows? Who knows what's around the corner? But Stiofan, do you have anything to add to that in terms of the appreciation of the part? I mean, responsibility is a huge thing, right? When you give somebody responsibility of the past, when you show them what's happened in the past, they take on a bit more responsibility for the future of the profession. Have you noticed that? Have you kind of observed that?
Yeah, look, I mean, I think that it is important to have some continuity with the past and to be exposed to that. And as I say, I have done when I've been in London, gone and taught there, and done a half day of this, that, and the other, and that seems to go down very well. They like to be exposed to people that come from the wilds of practice. There's talking about clinical interactions, talking about managing patients. I think that is really important. I think this is an observation. The British Medical Acupuncture Society, which I'm a member of, I've always really enjoyed their scientific conferences and then their annual conference, because it is so focused on practice and clinical stuff. It has to have a scientific component as well. But I think that is something which I've never had as a post qualification. I've never had a fraternity of osteopaths through professional associations or what have you. It's been ad hoc. It's been through people I trained with or people I work with. I don't think we're very good at organising the scaffolding around that. And that's not criticising a particular professional association. It was my experience in the UK that the British Osteopathic Association that then became the Osteopathic Institute, I believe, and so on, that they didn't really foster that. It was more about small business, kind of stewardship.
Yeah.
And nothing could bore me more than that. And nothing could bore me more than that. I just wouldn't, turn up for a lecture from a HR consultant about managing reception staff or, whatever, great building insurance. So I think that's been a profession-wide in different jurisdictions of all the countries I've lived and worked in. I've just thought that was really lacking. But I've got that from the medical acupuncture world, and that's sustained me quite a lot. So I think that's something that we should attend to. How that happens is probably a conversation for a different day. And but yeah, I think we do need to be more organised as peers. That's what I would say.
More
when I
generous.
work, I
Let,
mean,
let
I work with other
more,
osteopaths.
more.
There's people at Anne's Clinic I can talk to. I work in GP practice. I've been there for 13 years. I've got peers there that I could talk to in different professions. So I think my perspective is probably a little warped.
Mm.
Yeah. I did want to discuss internships, but I think we could do a whole episode on that.
Yeah.
So I might leave that for another episode and just leave it as a teaser. I think that's an important topic that we need to talk about and part of that future of education that we discussed earlier, Stefan. I think you said exposure to different practitioners, and I think if we have that within an internship model, it wouldn't be a bad thing, or we can discuss that. But I think we'll leave it at that tonight. We've had a pretty robust conversation about many different topics. Definitely, I think, Anne, will get you on to really extrapolate on your general osteopathic treatment, or the TBA, as Stefan calls it, total body adjustment. Total body adjustment sounds very infomercial, which I like about that,
Well, we
Stefan.
might have to do that with a patient on a bench at some stage. That might be.
Yeah, that'll be great. That'll be great.
Maybe
All
we
right.
should
Well,
maybe we should
everybody,
actually organize an in-person training session.
we
Okay.
could do that. We could definitely do that.
If only we lived
There's
in the
lots of
same
ideas out
city.
there. Yeah.
Oh yeah, actually we do. Yeah.
I did touch on this earlier, and I do have some courses coming up, but I'm not going to. But what I'm thinking of doing is, on the sidelines of running those courses, is to actually offer an hour or two for any students that want to come down and have a chat and just go through technique, and that'll be something that we do as an offering to the students. So. I'll put some more information about that through my channels. But Stefan, thank you for joining me, and as always, it's a pleasure. Stay on the line with me, guys, but for everyone else, thank you for joining me on this episode, and we'll catch you on the next one.
Bye-bye.
Bye bye.